Welcome everyone to this coaching corner on the 4th of May. I need to get my slides working here. So welcome to today's episode of the Coaching Corner. I'm your host, Suean. If you haven't yet done so, feel free to subscribe to our YouTube channel. And for all the ultrasound educators out there, sign up to our Facebook community, the POCUS Educator and Seed Support Network. I want to let everyone know that the session is being recorded today and will be available on our website in the next few days, along with all of our previous episodes of the Coaching Corner under the Resources tab on the homepage at ultrasoundtraining.com.au. Feel free to ask questions, and if you'd rather ask questions offline, let me know and we can come back to them at the end of the session. Otherwise, I'm going to try and figure out how to unmute everyone so that you can ask questions freely at the end. So tonight's episode of the Coaching Corner is inspired by the May the 4th. So May the 4th be with you. So we had kind of a Star Wars inspiration for tonight, and that got me thinking to what is Star Wars? And I'm not a big Star Wars fan, but there's Luke and Leia who are twins. So we thought we could do top tips for scanning twins. And so in today's presentation, I'm going to take a brief look at, my top how-to techniques for the first trimester and what we need to think about in first trimester. And then I want to move on to some tips for scanning in second and third trimester. So in early pregnancy, if we start with early pregnancy, it's really important that we have a systematic technique. And it's super important that we establish chorionicity and amnionicity. And that's because this will set up the management plan for the whole pregnancy, and it's crucial for successful management. Accurate and early prenatal diagnosis of amnionicity, along with enhanced prenatal and postnatal care, has been shown to decrease the mortality rates, particularly in your monochorionic and monoamniotic twins. So my first tip is that you need to be really systematic. And that means approach the scan in the same way each and every time, and make sure that you are scanning from the edge of the uterus, laterally, all the way through to the other side of the uterus. And then in transverse, you want to make sure you are starting at the cervix and scanning all the way and beyond a little bit the fundus. And the reason for this is because it's very easy to put your probe on the patient and just find a gestational sac and then get focused on that and then completely miss another twin. Now, if you want to get written up in the local papers or in the local tabloid magazines that, they missed a twin and I found it at 20 weeks, then sure, go and plonk your probe on and don't do a thorough scanning technique. But it's very important to scan all the way from the lateral to lateral edge of the uterus and the inferior, right from the cervix all the way to the fundus of the uterus, so that we don't miss any gestations. And if you have the situation like this baby or this pregnancy where there is multiple pregnancies, and we're talking about 7 gestational sacs here, it's really important that you go through and find all those. Now, hopefully you are not finding a higher order multiple gestation like this one with 7. The most common thing is twins, right? And so then it's really, really important to establish the chorionicity and amnionicity. So before we get too deep into that, let's just take it back a step. Twins are either dizygotic or monozygotic. They're either made from 2 eggs and 2 sperm, or 1 egg and 1 sperm that splits. Now, if we have dizygotic twins, now 80% of all twin pregnancies are dizygotic. And so that's where there are 2 eggs and 2 sperms. And so with 2 eggs and 2 sperms, they will always end up having 2 chorions and 2 amnions. Now they could be separated and, have 1 placenta implanting on the front and 1 coming in on the back of the uterus, or those placentas or those eggs or embryos could implant side by side, and so the placentas can seem like they're fused, but in fact they're just sitting very close together. So all dizygotic twins are dichorionic and diamniotic. For the monozygotic twins, so that's where we have 1 egg and 1 sperm, so that's about 20% of twin pregnancies. They can have varying different types of placentation depending on the timing of the division of the fertilized egg. And so about 30 to 40% of monozygotic twins are dichorionic and diamniotic. And again, this can then fit the same like the dizygotic twins, where you have two distinct chorion or placenta and two amniotic sacs. So that's when the egg splits quite early. So before day 3 at the Morellus cyst stage, you get two separate placentas that can either implant around the uterus very distinct and separately, or they can be like the dizygotic twins we just talked about. They can implant in the uterus quite close together, and then the placenta appears to be fused. If the egg splits, the fertilized egg splits a little bit later at the blastocyst stage, the time to division here is between day 4 and day 8 after fertilization, then the resulting pregnancy usually has one chorion or one placenta and two amniotic sacs. Now, if the embryo divides a little bit late, that is between 9 and 12 days after fertilization at the implanted blastocyst stage, this is where we get monochorionic and monoamniotic twins. And if it divides even later again, after 13 days from fertilization, or when the embryonic disc has formed, that's when we get conjoined twins, who are extremely rare. And so the monozygotic twins that are dichorionic and diamniotic accounts for 60 to 70% of all, 20% of all pregnancies are monozygotic. And of the monozygotic twins, about 60 to 70% of those are monochorionic and diamniotic. And so it's very, very rare that we see the monochorionic and monoamniotic twins only in about 1 to 2% of all monozygotic pregnancies. And so we've got lots of words here that I keep tripping over, but hopefully we can keep it straight. Essentially what we're talking about, dichorionic, diamniotic, you have two separate placentas and two separate amniotic sacs. Monochorionic, diamniotic, one placenta, two sacs. And monochorionic, monoamniotic, so this is the rare one, but it's really important for us to pick this up early because there might be intertwined blood vessels and the risk of twin-to-twin transfusions high. And you also have the risk where your cords can get tangled up. So this is where we have the one placenta and one amniotic sac. So what does that all look like on ultrasound? In the dichorionic, diamniotic pregnancy, we have two separate gestational sacs with a very thick intertwin membrane. And typically you'll have the two yolk sacs, or this one you definitely will have the two yolk sacs. In a monochorionic, so one placenta, two sacs, you'll have one gestational sac and two amniotic sacs. Now the amniotic sacs are a very, very thin membrane, and they're illustrated here. You can see there's a little sac around this one and a little sac around here. So we can see the two amniotic sacs here. Now typically in an MCDA pregnancy, you'll have a thin intertwin membrane and two yolk sacs. In a monochorionic, monoamniotic pregnancy, we have one placenta and one sac. And so you can see the two embryos here and the outline of the amniotic sac. Now, the challenge with the amniotic sac is we need to be perpendicular to it to get good specular reflection. It's a very, very thin membrane. So we have to be exactly perpendicular to it to get a good reflection. And that's why on this one, you can only see it sort of where we are perpendicular. You kind of lose the rest of the sac around the edge. Now, typically the thinking was you look for the number of yolk sacs to indicate how many amniotic sacs there are. However, there have been a couple of series of case studies done, one by Shen et al. That revealed that 85% of the 20 cases of monochorionic diamniotic gestations had two yolk sac, and that meant 15% were characterized by only a single yolk sac. And then later on in 2010, there was a case series done of monochorionic, monoamniotic twins having two yolk sacs, which means we need to be really, really careful here, and we need to actually look for the amniotic sacs because the number of yolk sacs is not necessarily as reliable as we once thought. Having said that, most of the time, so in 85% of the cases, it's probably going to steer you in the right direction. But just keep in mind that sometimes you can have anomalous sort of presentation of how many yolk sacs they are. How this translates for our practical scanning, we need to make sure that we actually look for those amniotic sacs so that we can define what the pregnancy is. Is it dichorionic or monochorionic? Is it diamniotic or monoamniotic? Because as I mentioned, that's really important for the ongoing management of the pregnancy. So taking a bit further look here, we've got a couple of examples of a dichorionic pregnancy here. So you can see the very thick intertwin membrane and the two separate gestations. And again, over here, two separate gestations, and we just happen to slice through here where we can see the yolk sac in both those gestations. Here we have a monochorionic pregnancy, diamniotic at about 6 weeks. So it's the classic sort of diamond ring stage. You have the yolk sac here with a tiny little embryo under my dot there, and another yolk sac here with a tiny little embryo. Pregnancy progressed, two yolk sacs here, two separate amniotic sacs coming around here. And the monochorionic, monoamniotic, typically we have the one gestational sac and typically one yolk sac, and we can see both the embryos here in the one sac. Now, as the pregnancy progresses a little and the placenta starts to develop, then we can start looking for the lambda or the twin peak sign or the T sign. So we look at the thickness of the intertwin membrane and we look at the junction of where they come together. So if you have the circumstance where it's either early division of a monozygotic pregnancy or it's a dizygotic pregnancy, but the placentas have implanted side by side on the uterus, we can tell that there are two distinct placentas here by the thickness here of the intertwin membrane and this lambda sign just coming through here. You can see over here that very distinct lambda sign, the two sacs and the two amniotic sacs, and it's a really nice example of the amniotic sac here. On the other hand, if they are monochorionic, diamniotic, what we're looking for is the T sign. So this indicates that there is only one placenta. The membrane is quite thin and it forms a T at the edge. And so you can see here we have placenta and the T sign here of the intertwin membrane. And another example, we have the placental mass around here and the T or the very thin intertwin membrane. So that's where we have the one placenta and the two amniotic sacs. So when we only have one amniotic sac, you don't see a membrane at all. And so everything's all very confusing here because limbs and everything, especially the further along you get in the pregnancy, the limbs are all mixed up in amongst each other, and you do not see an intertwin membrane. So this is one amniotic sac, no intertwin membrane. So now we'll move on to some tips for second and third trimester. And the very first thing that I always do when I have a twin pregnancy is to read the previous reports. Most of the time I don't like to, and this is a real personal preference thing, I don't like to be biased by what someone else has seen. So I will do my scan and then go and check and compare it with the others and try to make sense of what I'm seeing so that I'm not biased. The one exception to the rule I have is when I'm doing twins, and I will always read the previous reports because I want to, first of all, notice what the naming convention is. So if they've called it left and right, left twin A, right twin B, or if they've called it superior or inferior, I want to see what naming convention they've used and what the previous person's opinion was of which was the presenting twin. And that's so that when I perform my scan, regardless of what my opinion is of which one is presenting, I be consistent with the naming of the twins so that the measurements that I'm taking are of the same baby and can can be compared to the baby from before, so that they scanned before, and so we have consistency throughout the pregnancy. The next step is to make sure when you set up your machine that at the patient data entry phase that you actually select a twin pregnancy. Now, some of the machines have got higher order multiples. If you haven't got higher order multiples and the option to choose from 3 or 4 or whatever, then you probably just have to do separate scans. But it's important to make sure that you do choose twins at the patient data entry stage, because that sets your machine up so that when you're starting to do your measurements, you can enter the measurements as 2 separate babies and keep those babies' measurements under their own sort of banner. And so once you go into the calculations package, you then just need to be mindful to choose fetus A or fetus B, whichever one you're scanning at the time. My next step is to start with the fetal position. So I spend a bit of time trying to figure out the lie of the land and figure out where everyone's lying and where the placentas are and what the placentas are. Have I got 1 or have I got 2? And can I see the membrane? So I'm just trying to get an overall image in my mind of how these babies are lying. Now, obviously, if they're both vertex presentation or even both breech presentation, you've got arms and legs tangled up together and it can be really tricky. But we need to kind of figure out, well, which way is the spine for each baby, and just get an image in our mind, even draw it down if you like, and keep it there as a note for yourself so that you can follow up and make sure you're staying on the same baby. So to determine the fetal lie, I'm starting in the transverse orientation, and I place the probe just above the symphysis pubis, and I'm trying to find if I got heads or have I got feet or have I got back. What can I see here? I then track straight up the middle of the tummy, again, to try to figure out, have I got one baby then the other and they're lying on top of each other, or are they lying side by side? And then it's a case of systematically scanning from one side of the abdomen to the other to figure out where everybody is. The other thing that I do at this stage is just try and find those placentas so that I can figure out, are they together? Have we got 2 separate placentas? What's going on, and just to evaluate the placentas as well. Now, when you're labeling the pregnancy, apart from looking and seeing what has been done before you, it's really important, I think, to do more than just label it twin 1 and twin 2, because sometimes I've found that there may be a difference of opinion of which one's coming out first and which one is the presenting twin. So I always label the pregnancy or the twins as right twin or left twin or superior and inferior, and then twin A or twin B or twin 1 and 2, whatever the convention is at your place. So for example, it ends up being right twin A, left twin B, or vice versa, or superior twin B, inferior twin A. That's so that the person following me can track and monitor and make sure that they're measuring the same baby and that the measurements for that baby are consistent and stay with that baby throughout. The next really, really important thing, and I've asked around the office today and pretty much everyone has come back with the same tip: scan one baby at a time. The very, very first twin scan that I ever did, I'd not done very much obstetric scanning, and I made a right mess of it. I still didn't really get where things were or how to purposefully get the image that I wanted. And so it was just whatever kind of came up. I got to the end of my scan and my images, my growth, as I mapped out the growth for each of the babies, it was all over the shop. I had actually put wrong legs into twin B with twin A's head, and it was just an absolute mess. And someone had to pretty much start from scratch and repeat the scan. So mum was tired by this stage because I'd been going at it a while. And anyway, that was good because it flagged that I needed some help with this. But the biggest lesson out of that for me is to scan one baby at a time. And so the reason for this from a workflow perspective is so that you don't get too confused and you can keep everything together, but also just for efficiency in making sure that as you go into the calcs package, you've scanned baby A and you're in baby's A calculation package, you put all the measurements in. Once you've finished baby A, you move on to the next one and you change it in the calcs package, and then all the measurements that you take are in the right report for each baby. The other thing about scanning one baby at a time is that it's really important that you don't get distracted. Now, sometimes these babies can do some really cute stuff, but you don't want to be on one baby and the other one starts doing cute things and you get really distracted and veer off on a tangent. So stick to one baby at a time to keep everything in order. It's super important in anything obstetrics or anything ultrasound really, but even more so with obstetrics, that you be really systematic in your approach. So try as much as possible to do things in a similar order so it's easier to remember what you've done and what still needs to be done in this scan. I know when I first started scanning, I pretty much was on the machine and said, here, how you go. And I couldn't purposefully get an image if I tried at that stage, but I used to just tick it off and hope the baby would roll over for me and get into a nice spot. But what happened then is you're all over the place and it's really hard to remember which images you've done and which images you haven't done. And so where you can, you need to be very systematic. So in third trimester, that might be, we start with the fetal biometry to get our growth parameters going. I then do the AFI or measure the deepest pocket on each side of the membrane, followed by the umbilical artery on that baby. Take a bit of break and I'll come back to that, and then start the next baby. In second trimester, I've just pushed something here. Hang on, we're just gonna, there we are. Now, in second trimester, even more important that you have a system. And the way that I kind of break up my scan in second trimester, I do all the maternal structures first. So I'm looking at the ovaries and the cervix and placenta and everything that's not baby. I do that first. And then depending on how baby is presenting, or which baby at a time, which is in the best position to get started, I do everything in the abdomen. So stomach, kidneys, umbilical artery or cord insertion, bladder, umbilical arteries. I then do all my spine pictures together when baby's in a good position for that. I then do all my head together, all my heart together, all my limbs together. Now, some people might separate and go, I'm just going to start with the biometry and do biometry as a block, and fair enough. I kind of put it in as in amongst the abdomen, the head, and the limbs as I'm doing those things. Really important to have that system, because then you're just remembering one group of things at a time. And if you haven't been able to get one picture, it's easier to remember I haven't got one picture than it is to remember I've done 7 out of the 10 things I need to do. And so I follow this structure. I do one whole baby and be very structured about it. When I finish that baby, take a bit of a break and then do the next baby. And it's kind of like intermission. It's intermission for me. So I've got some mental space between the babies, so I can try to create that space so I don't confuse what have I done and what haven't I done. But also, you know, it's an opportunity for you to say to mum, hey, why don't you roll over or sit up for a moment, take a bit of a breather. You change your calcs over and change your calc package over and get ready for the next baby. And it provides that distance so that you can keep everyone in their spot and make sure you're not getting things confused between the two babies. The other thing that's really confusing scanning twins, especially later in second and third trimester, there's a lot of action and there's arms and legs going on everywhere in there. And so it's really tricky to follow and decide which bit belongs with which baby. And so the way I get around this is to establish a home base. And so I always start at the abdomen. I pick the abdomen because the legs aren't too far from it and the arms aren't too far. Find the abdomen of the one baby and everything comes from the abdomen. Go back to the abdomen, come up to the head, then go and do limbs, come back to the abdomen, go and do the bottom part, measure the things, come back to the abdomen. The other thing about this is when there's lots of arms and legs, it's a way to just take a breath, get your thoughts back together, come back to that home base as a sort of calming motion, and then track your way back to find the next structure. Now, I do this if I'm scanning single babies, but even more so and more importantly, in the twin gestations, because those arms and legs can be mixed up with each other, and I want to make sure I'm on the same baby all the time. Now, a couple of final tips here. When I put out the call to say, hey, we're doing twins assessment for this coaching corner, one of my friends got in touch with me who is a mum of twins, and she said, you have to remember to tell people we've got not very much pelvic floor left when there's two babies jumping on it. So they always need to go to the toilet. Be mindful of the full bladder. So be as quick as possible, she said. And the thing with this is in third trimester, you probably don't even need to have a full bladder, even sometimes in second trimester. If you can keep your patient comfortable, they need to lie there for quite a while. So be mindful that that bladder doesn't take much to fill and it becomes really uncomfortable. And the other thing she said, particularly in third trimester, it's really hard work for mums lying on their back when there's so much weight compressing on their on the IVC, so they can get quite dizzy. So if you can pop mums a little bit rolled on their side and then scan that way, then it just makes it more comfortable for them. So they're my tips, and that's what I've got for you for today's episode. If you found this episode useful or helpful in any way, feel free to refer your friends and colleagues to the resources section on our webpage. Or you can subscribe to the YouTube channel, as I said. But now I get to throw it over to you. Has anyone in the audience got any other tips that they use when they're scanning twins? Or have I missed anything really obvious that you would like to share? Or are there any questions from the audience? All righty then. Well, thank you so much for joining me tonight. I hope may the force be with you tonight. I hope you all have a great evening. Thanks for joining me, and hopefully we'll see you next time.